Good afternoon. It's 12:30 and this is the beginning of the first webinar from the Piers Cumbria School of Medicine, the CumbriaMed Research Webinar Series. So Piers Cumbria School of Medicine, or PCSM as we call it, is the first medical school to be established in Cumbria and will open its doors for new students in August of this year. We're immensely pleased to be a partnership between Imperial College London and the University of Cumbria, together with North Cumbria Integrated Care NHS Trust, NCIC, and other NHS partners across Cumbria. As part of what we do, we're going to present a monthly seminar series on topical issues in medical research of interest to the population of Cumbria. Particularly focusing on some of the most common medical problems and where we can bring international expertise in research from Imperial, together with the expertise locally in Cumbria from the hospital and from other NHS partners. So without further ado, I'd like to introduce our first speaker, who's Professor Hashim Ahmed. Hash is a Professor of Urology at Imperial College London and Honorary Consultant Urologist at Imperial College Healthcare Trust in West London. And Hash is an international expert on diagnosis and therapy of prostate cancer. Hash, over to you.
Jonathan, thank you very much, and thank you to Hugh and Kathie as well for including me in this panel. It's a real pleasure and privilege to be here, and I wish you the very best with the Piers Cumbria Medical School. I think it's a fantastic initiative, and very much look forward to seeing its success. So I'm a urologist. I spend half of my time doing clinics and doing operations. I'm in surgical scrubs today because I'm halfway through one of my operating lists, but it's great to be here. And I spend the other half of my time doing research in how to improve the diagnosis and treatment of prostate cancer, mainly through clinical trials which inform practice and hopefully change practice. Whenever I give this talk, I always say we are all conflicted. I've made my career in this. I make money from it personally, and my institution makes money from all the grants that we bring in. So we are all biased when we talk about these things, and it's important for you to know that. I'm going to primarily shape my talk around screening for prostate cancer because it's very topical at the moment. But there are a number of issues that we all need to be aware of as to why screening is not approved and why many people are pushing for screening to be approved in the UK. And for those of you who don't know, the only country internationally which currently has a formal screening program in their country is Lithuania. Don't know why, but there was, for some reason, that was approved. But no other country across the world has a screening program for prostate cancer. And I'll explain why that is the case, certainly from a UK perspective, and how we might be able to get to a point where it could be. There have been a number of clinical trials which have compared standard treatment or standard diagnosis with screening. And screening is where we are looking for a certain disease, in this case, prostate cancer, in its early stage, so that we might be able to treat it before it becomes more advanced and causes the life expectancy of that particular individual to be shortened because they die of metastatic cancer that spread. And whilst early diagnosis certainly sounds really good, the data has not been that clear. So this is a UK study where they took over 300,000, close to 400,000 participants, men, between the ages of 50 and 69, and they randomized them. So a computer decided whether they would be in the control arm where they just carried on in their merry way in the community. If they thought about getting a prostate test, they would go off and have it, but they wouldn't be formally invited. And the intervention, which was to be invited to have a blood test called prostate-specific antigen, which we know, if elevated, can carry a risk of that man developing prostate cancer. And so these men were screened in the intervention arm. And this graph shows you, as you go down through time, what proportion of men died of prostate cancer for each of those groups. And as you can see, the two lines are effectively overlapping. There's a little bit of parting as you reach 15, 16 years. And that tiny little mortality benefit is what we are starting to see in this particular study, but it's taken 16 years to show it. It's a small benefit, and it's taken about 400,000 men to prove that small benefit. So we're not doing quite well on that. This is the US study. And the US study, again, they looked at randomizing men between control and screening. And in this particular study, they showed no benefit. Interestingly enough, you can see that the death rate from other causes is quite high. What they found in this study, though, is that men in the control arm, those who shouldn't have been screened, they knew they were in a study on prostate cancer screening. And so the majority of those men went off and asked their GPs for a PSA blood test and effectively got screened. So the control arm wasn't quite the normal control we would get. So this was comparing intensive screening with a less intensive screening. And so they found no difference between those two groups, but their study was maybe flawed because the control arm went off and did a lot of testing on their own. The European screening trial in prostate cancer was really the key study that everybody's been looking at as proof that screening for prostate cancer makes a difference in terms of survival. And they showed that there is a difference in mortality benefit. If you screen for prostate cancer, you will improve life expectancy compared to a control group. And in this particular control group, men didn't go off and have as many PSA tests as the US study did. The key difference between the European study and the UK study is that they continued to screen on a regular basis. It wasn't just a one-off test. They tested men every 2 years on average. And so regular testing for prostate cancer in a screening program was one of the key things that they did. However, the conclusion from their study is that there were too many harms from screening that made people concerned that screening wasn't necessarily a good thing to do. And I'll come on to touch on what those harms are. The other issue with the European screening study is that it involved a number of countries, and the benefit in terms of mortality was only shown in 2 countries, and both of those in the northwest Scandinavian region of Europe. Those starred with red did not show any benefit with screening, and France's data was excluded from the study, even though they had completed it, because there was some issues with the data quality. We don't quite know what, but France was excluded. And so there's still some uncertainty as to whether this study actually showed a benefit, or whether that benefit is, strictly speaking, only in Scandinavian countries where the populations there are much more homogeneous in terms of their genetic makeup. So potentially some benefit in terms of life expectancy, a lot of uncertainty though. But when a man tests positive with a PSA blood test, so if it's high, do we have a good test to find the cancer afterwards? So we don't diagnose prostate cancer on a PSA test. The PSA test leads us to another test. And what we have found is that when we, in the past, used to diagnose prostate cancer, men went straight to a biopsy, what was called a systematic biopsy, through the back passage, and you would throw needles into the prostate in the hope that you would find cancer. And that test was inaccurate with about 50% sensitivity. It was inaccurate because it missed cancer. It found lots of small little cancers that were not important enough to be treated, but men went off and had treatment and had problems in terms of those treatments from side effects. So that test, what we call the trust biopsy, was very inaccurate. And in the US, it still goes on. In the UK, we have moved from doing random biopsies to doing an MRI scan. And an MRI scan uses magnetic waves to give us pictures of the prostate. And hopefully you can see my cursor, but this is the prostate here that I'm outlining. The back passage is here. And this area that looks slightly darker is the tumor. And when you look at how water molecules move through the tissue, you can see that this area lights up and this area is darker. And that gives us confidence that that area is highly likely to be a tumor. And we've now cut this type of scan time down to about 10 minutes, what we call the prostagram. And this was shown in a study to be highly accurate in finding cancer compared to a PSA and compared to a trust biopsy. So potentially we might move to a prostagram type approach to screen for prostate cancer rather than using a PSA test. And the prostagram study was something that we led on a few years ago at Imperial. It was a key practice-changing study. When we find prostate cancer and we treat it early, when it's contained in the prostate, does that treatment benefit patients? And again, for those of you who are not experts in the field might be wondering, hang on, of course it must benefit. You found cancer early, it must make a difference to that man. And the problem is it does, but by a very small amount. So again, you'll be used to seeing these graphs now. If you compare removing the entire prostate to not doing anything, and this study was done in Scandinavian countries many, many years ago, they showed that yes, if you remove the prostate when there's cancer, there is a survival benefit. But that survival benefit, if you compare this dark gray line with the black line, is 5%. So there's a 5% improvement in survival at 15 years if you remove the whole prostate compared to doing nothing. So there is a benefit, but that benefit is small. The US study, this is the US pivot study, did exactly the same thing. They randomly assigned men to having observation, monitoring only versus prostatectomy, and they showed a smaller benefit, but it took almost 2 decades to see that benefit in survival. So a small benefit, but really quite small. And this study from the UK called PROTECT was really sort of groundbreaking and made us think and rethink what we were doing. So this is a study which diagnosed men early using screening for prostate cancer using a PSA test, and they randomized them to active monitoring, so not doing anything until the cancer changed, and then you would treat, compared to radiotherapy to the whole prostate, compared to prostatectomy, where you would remove the whole prostate. And the survival benefit is 0 over a 15 to 17-year period of follow-up after treatment. So there are 3 lines here, but you can hardly see those 3 lines. So no benefit in treating everybody who is diagnosed early. This graph shows that when you monitor men, those men do stand a higher chance of getting metastases, of the cancer spreading. So they are put at detriment from being on monitoring, but it doesn't seem to make a difference in terms of eventual survival. So we've had to really rethink whether we're doing the right thing by treating everybody. So potentially a small benefit in the higher risk group of men who have early cancer, but certainly not a survival benefit for all men who are diagnosed. That would be fine if the treatment itself didn't cause so many side effects. So treating the whole prostate with surgery or radiotherapy causes significant urinary and sexual side effects. And that is because the prostate is in a very sensitive region. It's close to nerves that control sexual function and urinary function. It's close to the muscle that stops you from leaking urine. It's close to the back passage and the bladder. And if you treat the whole prostate, you will damage those other organs, those other tissues to some degree. And so we've learned now that if you have surgery, you have a 35 to 47% chance that you will need to wear a pad a day for the rest of your life. With radiotherapy, that risk is 5%. The chance of men losing erectile function for the rest of their lives, even with Viagra, is at least 50% on average. And with both of these treatments, and back passage problems, because you can get spillover radiation no matter how accurate you think the radiation is with modern techniques, up to 15% of men will get bleeding, discomfort, and loose stools for the rest of their life. And these treatments still have some degree of failure. So there is a big impact from treating with potentially little to no benefit in terms of survival. So some people have said to me, well, surely saving lives takes absolute precedence over everything else. Men should just be treated, they should just accept those side effects because it's saving their lives. Well, first of all, we've seen that it doesn't actually, in the vast majority of men, save their life, doesn't extend their life. We don't know which men truly benefit from that treatment. But we also know from this study, which I did, in over 500 men who were newly diagnosed, we asked them what's important in their life. And patients, men with cancer, were willing to trade survival for having a better quality of life, whether that was better erectile function or better urine function. And they were willing to survive less time in order to have a better quality of life. So men are willing to, on average, make those trade-offs. So who are we as doctors to tell them otherwise? So we have now started to get better, and we are now monitoring, or what we call active surveillance. We are doing active surveillance in a lot more men with early low-risk prostate cancer. In the UK, about 90% of men with low-risk cancer, which has been found early, is actively surveyed. And that means we're monitoring the disease regularly, and if at any point there's sign of progression, we then treat and we act at that point. And that strategy is very safe. You don't lose the window of curability. So we're doing a lot to mitigate against the harms of immediate treatment, which is fantastic. There are still some unknowns, though. We don't quite know how many men stay on active surveillance. There is a burden of regular testing, anxiety, psychological burden. And we also don't know how many medium risk cancers that could be monitored with active surveillance are monitored with active surveillance. There's some uncertainty around that. So we can do better, and we need more data on this. And we mustn't make the mistakes of previous generations where you found cancer, you remove the whole thing, you remove the whole organ, and so be it. Over the last 10 to 15 years, and the UK has really led on this, we have done much better in how we diagnose cancer. I've shown you an MRI scan before. This is another MRI scan. There's the prostate, and the circle here shows you that dark area with the tumor. And that has completely changed how we diagnose prostate cancer. But what we haven't done is take that information and treat in a better way to try and reduce the side effects until maybe the last 5 to 10 years. We spend so much time finding that one tumor, and then we throw it all away by treating the whole prostate. And so within our next program, which we call Transform, looking at screening, we're not going to make that mistake. Because there is an alternative treatment called focal therapy. This is the equivalent of lumpectomy for breast cancer, where rather than treat the whole breast, you remove the lump. With focal therapy, rather than treat the entire prostate, which we know causes all of these side effects that you can see here, if you treat just the tumor with freezing or heating it up, you can't quite cut it out. So it's not a lumpectomy as such. The paradigm is similar. But you burn it, or you freeze it, or you electrocute it. By treating just the tumor, you're causing much less damage. And that leads to a 5 to 10-fold lower risk of side effects. You're talking about almost 0% risk of leakage of urine compared to those rates that you've seen previously, and a 5 to 10-fold lower risk of erectile dysfunction and bowel problems, with actually no detriment to survival or local recurrence risks. So we can do much better, but the problem with focal therapy is that there is very little adoption. Surgeons who do robotic surgery want to take out the whole prostate because that's what they've learned. Radiotherapists have a radiotherapy bunker. There's been a lot of investment in it. That's what they know, that's what they've learned, and they want to do radiotherapy. So adoption of innovation is tough in the NHS, but we are starting to see some movement on this, but we need to do more to try and reduce the risks of treatment. And then the other thing that is impacting on screening is that we are actually doing much better in treating the advanced cases of cancer, those cases which have started to breach the capsule. There's been spread to other areas. New drugs, new forms of treatment have actually improved the life expectancy of those men. And that might be enough to offset any advantages that we see in survival from screening. So because we've done so much better in this space of treating really high-risk cancers, we may not see the benefit of screening for early cancer in a new study. And so this is something that's also needs to be accounted for. In fact, over the last 20 years, last 10 years, 10 to 20 years, we have seen so much of an improvement. The average life expectancy has gone from 3 years, 20 years ago, to 5 years, 10 years ago. And I've seen data which shows that it's creeping up to 6 to 6.5 years over the last 10 years. And so over the last 5 years. So We're doing much better because there are new drugs coming out onto the market almost every 2 or 3 years. And that's pushing the life expectancy out. And for screening, where government is going to have to invest hundreds of millions of pounds to set up a screening program like it has for breast cancer, like it has for colorectal cancer, lung cancer screening is starting to be funded as well. We have to, in the NHS, talk about money because this, if there's a finite amount of funds, then this will take funds away from elsewhere, or the government is going to have to find money from defense or social care or education if the NHS budget is not to be touched. So we know if you plan this out and if screening is successful, we are going to need so many more MRI scanners. We are going to need so many more people to run those scanners, radiographers, technicians. We're going to need radiologists to report those scans. And yes, artificial intelligence might help us in some of those things, but it won't be a complete solution. We're going to need urologists to review those patients, to do those biopsies, to treat the patients, with oncologists in partnership. We're going to need pathologists. There's already a shortage of pathologists, and to report the existing number of biopsies that we do. We're going to need our very important nurses and all of the other allied health professionals. And we're going to need a lot of managers to help us manage these programs, because managers are really, really important in healthcare.
We're going to be tight for time.
Yes. So there is a lot of conflicting evidence on whether screening works or not. So this is my last slide. We know prostate cancer is important. We sort of understand its natural history. We can find it at an early stage, but we're not quite sure which tests to use. We know how to do screening, but once we find cancer, we're doing a lot more active surveillance, but our active treatments like prostatectomy and radiotherapy are harmful, and we need to do better in that front. And we need to demonstrate cost effectiveness. We need to show that it's beneficial both clinically for those men, but also cost effective and beneficial for our wider public health. Thank you very much.
Ash, thank you so much for that terrific talk. I'd like to introduce Kathie Wong, who's a consultant urologist at North Cumbria Integrated Care NHS Trust and a researcher on the treatment of prostate cancer. Kathie.
Thank you, Jonathan, for the introduction. So I'm going to talk to you a bit more about the treatments for prostate cancer and a bit of research that we're doing in this area in Cumbria and why it's important. So as you've already heard from Professor Ahmed, the overall men are living longer with prostate cancer than ever before, in part because we're better at finding the cancer using MRI scans, and in part because of better treatments for prostate cancer. Now, we know that it's important in some men to find the prostate cancer early and treat it early. However, at the same time, for other men, they may be living with prostate cancer that will never affect their length of life or quality of life. And there's a whole spectrum of different presentations in between. So prostate cancer is not one cancer. It can behave very differently in different people. You've already heard about the PROTECT study, a UK-led study, which gives us evidence for active surveillance. So this is in men who have a slowly growing non-aggressive prostate cancer. We don't need to treat their cancer immediately, and we can keep them on monitoring with regular blood tests and scans if necessary. And the data from the PROTECT study goes up now to 10-15 years, showing that active monitoring versus radiotherapy versus surgery shows no difference in survival between the three groups. So in a similar way, there may be some men in their later ages or who have other medical conditions who may not benefit from treatment and may not die of prostate cancer. So these men may go on watchful waiting, where we only treat the prostate cancer if there was signs it was becoming more aggressive and escaping the prostate. So I want to highlight that the landscape for treatment of prostate cancer is vast and it's evolving all the time. I'm going to focus on the treatments on the left-hand side, but as I say, I wanted to show that we have ever more new treatments for prostate cancer. I think historically, we were very focused on good cancer control. But as Professor Ahmed has also mentioned, we're now realizing that it's gaining more importance of minimizing side effects of treatment and also helping men to have a good quality of life beyond their cancer diagnosis. Some men with prostate cancer that's confined to the prostate may be suitable for surgery. And this has evolved over the decades. So traditionally or historically, we used to do this as an open surgery where we make big cuts into the abdomen to get down into the prostate, which is a very deep pelvic organ, to remove the prostate gland. And nowadays, probably in the UK exclusively, this is done by robotic surgery. And that doesn't mean the robot does your operation. It does mean that there's a surgeon at the console who's directing the small, fine robotic instruments within the abdominal cavity, using small cuts in the skin wall. And the robotic surgery shows a quicker recovery, the wounds are smaller, and there's less blood loss compared to the original traditional open approaches. However, it's still a surgical operation, and as already mentioned, there can be side effects, including urinary issues, the risk of urine leakage, and erectile problems. Now, some of you may recognize the building on the top, which is the Cancer Center based in Carlisle. And some of you may even recognize the suite where radiotherapy is delivered. 4 in 10 men in Cumbria will have radiotherapy as part of their treatment for prostate cancer. And there are different ways to deliver radiotherapy. Radiotherapy can be delivered externally. So this is using high energy radiation beams to target the prostate to kill the prostate cancer cells. It can also be delivered via putting in seeds internally into the prostate to emit some radiation over time to kill the prostate cancer. The side effects from radiotherapy come from the fact that radiotherapy will damage cancer tissue as well as normal tissue and some of the surrounding structures, such as the bowel and the bladder. So some of you may have heard of SABR or have had SABR treatment for the prostate cancer. So radiotherapy techniques are evolving all the time to become more precise. With SABR treatment, the treatment is delivered at higher intensity over a shorter period of time. And because it's more precise, it's aimed at reducing the side effects from the more traditional techniques. And of course, you may recognize the photo on the left, which is our esteemed guest speaker, Professor Ahmed, who's mentioned already about focal therapy. So the idea here is not to treat the whole prostate organ, but just to treat the area of prostate cancer. And we can do this by delivering heat energy or by freezing the cancer, depending on the location and the anatomy of the prostate. So why is research still needed in prostate cancer? We do need better tests. As you've heard, we need better treatments that help men to have a better quality of life during their treatment and after treatment as well. And here in Cumbria, we are involved in several national research projects to do with prostate cancer. The Pacific and the Atlas trial are led by Professor Ahmed and his team at Imperial. So Pacific is a trial looking at comparing 2 different ways of doing an MRI scan and 2 different ways of doing a biopsy. And we're about to join the Atlas trial, which is looking at ways of better ways of monitoring men on active surveillance. We are also part of the Oscar trial, which is a study led by a team in Wales, looking at biomarkers of different types of cancers in urology, including prostate cancer. And here in Cumbria, we are leading on a trial called the COSTAR study, which I'll tell you a bit more about. So we know that prostate cancer, radiotherapy, and men with an enlarged prostate can have urinary symptoms. And we don't really truly understand what happens when we combine all of these 3 factors. We know that quite a lot of men who have prostate cancer have an enlarged prostate, and these symptoms caused by the enlarged prostate can get worse during radiotherapy and after radiotherapy itself. So there is a risk during treatment of not being able to pass urine altogether. And there's also a risk in the long term of these urinary symptoms affecting quality of life. So the COSTAR trial looks at ways in which we can help protect the urinary function of men having prostate cancer radiotherapy. And this trial is open in Cumbria. It's sponsored by the Royal Marsdens. It's open in London, in Newcastle, and in Birmingham. So traditionally what we do is for men with an enlarged prostate going on to have radiotherapy who might run into difficulty, we offer them an operation called a TURP, which stands for transurethral resection of the prostate. So this is an operation that's generally performed under anesthetic. So you either put to sleep or the bottom half of your body is numbed by an anesthetic. And we pass a telescope into the prostate cavity to shave away the prostate tissue, to open up the prostate cavity to allow better flow. And this helps men to get through their radiotherapy treatment and beyond. And we ask the question, is there a safer, quicker option that we can do this? So Urolift is a technique that is widely used in the UK for men with an enlarged prostate, but it's never been tested in men having prostate radiotherapy. Instead of cutting away the prostate tissue, we put pins into the prostate to pull aside the prostate tissue to improve the flow and improve the emptying. This procedure can be delivered under a local anesthetic in the clinic. And in studies in benign settings, so in men without cancer, the recovery is a lot quicker. So what did we learn from doing the COSTAR study? We found that patients really benefited from the participation of clinical trials. They told us they felt that they were getting better care and that their cancer is being monitored more closely. And this was reflected in a high level of recruitment in Cumbria. So we recruited 50% of patients from Cumbria itself. As clinicians, I think we also found and saw improvements in the care that we were giving to patients and streamlining of some of the clinical pathways. So we now have a bigger vision to run COSTAR 2, which is where we're going to compare lots of different treatments for men with an enlarged prostate, for men going on to have prostate radiotherapy. And what we want to do here is focus on both the short and long-term outcomes of what matters most to patients. So this slide just shows the various different options of ways to manage a big prostate. So we can steam the prostate. We can use water jet therapy to get rid of the prostate tissue. iTind is a device that's deployed within the prostate to stent it open. And there's various different laser techniques, again, to shrink prostate tissue. So there are lots of different options out there, but we don't know which one is best for men going on to have prostate radiotherapy. So in summary, I think as we've shown with our slides, men are living longer with prostate cancer. I think treatment should be driven to help men live well with prostate cancer, minimize the side effects, and maintain their long-term quality of life. And we have seen in Cumbria how research can benefit patient care and our patient care pathways. So these are some resources. Prostate Cancer UK is a great resource for everything about prostate cancer. Thank you very much for listening.
Kathie, thank you so much for that presentation. On behalf of the audience, can I thank Professor Hashim Ahmed, Ms. Kathie Wong, most sincerely for fantastic presentations and brilliant Q&A. Can I thank everyone who has attended today? There is a questionnaire we'll be sending out. Please give us your view about the webinars. Our next one will be in a month's time, 4 weeks' time, Thursday at 12:30, where we will be looking at cardiology with a particular focus on atrial fibrillation. Thank you so much for attending. Thank the speakers enormously for their time. Thank you.